Wonderful, Matt. Good morning.
Good morning.
What a day to join us. So, Matt, first of all, the same as I said to I think, over 250 participants that already joined us and more that will come. Thank you. Thank you for taking the time to what is a very busy, challenging time to come and share what this year has been and what next year, in your view, will be. So before I leave you with the mic to share your thoughts, just to let people know a bit about you, but very briefly, because the bios are in your package, so we will not provide all the bios. So Matt Anderson is, as you know, the head of Ontario Health. And Ontario Health, you may remember, is the agency, the largest merger actually in the healthcare history, at least in this province. In some other countries, maybe that are larger, I don't know. But bringing together 20 agencies and over 12,000 staff that work with Matt. Matt has done, the entire merger happened just before the pandemic, or the epidemic, then became a pandemic. And Matt has done a tremendous, I would almost say, Matt, heroic work in the midst of some very challenging, and he's not saying it, but I will, some very challenging policies to try to keep the ship moving in the right direction. This work will continue, of course, in the weeks and months ahead, as we tackle what is in front of us, and hopefully into the future as we tackle a recovery and finally can move to better times. Matt, before you take over, let me tell you that RNAO is very involved with Ontario Health teams. I think the silver lining of the pre-pandemic transformation, we work directly with 7 of them on evidence-based practice in a formal agreement that is called BPSO OHTs. And I have been privy to be in their broad meetings of leadership, as well as with my colleagues on the front lines of the implication and the execution of those ideas. And I can tell you with no doubt that OHTs are the way to go. Pre-pandemic, certainly during the pandemic, they have performed. So I want you to take back at least a bit of, joy that some of these reforms have worked very well during the pandemic. So Matt, on to you, please, to share with us your thoughts. And just so you know, Matt has experience in hospital care and in various other sectors. He was the CEO and president of Lakeridge, if I remember correctly, just prior to coming to us. And also there, by the way, that too was a BPSO. And I think I wrote to you one day because it was in the front page of your website that you guys were a best practice spotlight organization implementing our guidelines. So Matt, thanks for your expertise, experience, and share with us the present and the future.
Wonderful. Well, thank you very much, Doris. That was very kind of you. And thank you, everybody. It really is such an honor and privilege to come and speak with you today. And today, you know, as unfortunately has been for us for a little while now, it's a difficult day. We have COVID running fairly unchecked right now. And a little sliver of good news has been coming in the numbers. Too much of a sliver to say we're through this, but we've got to, you know, work together. And all that I can say is that all of you, both personally and professionally, this has got to be an incredibly challenging time. I know it is for me and for my family, and I'm sure it is for all of you. So thank you. Thank you for everything that you've been doing and how you've been able to continue to remain focused on your role, on your patients, and on your community. So thank you so much for doing that. And thank you for the honor to come and speak with you today. We're scheduled for about 45 minutes. I'm going to try to get through my stuff relatively quickly, and if it's okay with Catherine and Doris, take a few questions. I always worry, if I use the entire time, I worry that I talk to you about what I want to say and I don't hear from you what you want to hear. So we'll see if we can save a little bit of time for questions in there as well. Just a little more on my background. Doris did a wonderful job of introducing me. I have been at Ontario Health for about a year, and Doris is right. I don't know if it was the best career choice I've ever made, but timing wise, I arrived about 3 weeks before the pandemic started. And so that's been a bit of a challenge. I don't actually know my job without the pandemic. So I'm going to tell you about what I think my job is supposed to be as we go forward. Previous to Ontario Health, I did work at a number of hospitals, and I would hope that all of you would see my support of nurse practitioners in particular. I would put myself in the good, not quite great category, good category. And the not quite great is I didn't get as far as I wanted to around where the role of nurse practitioners in hospital and community care, and happy to explore that some more if you'd like. But did do some really wonderful things. Nurse practitioners, both at Lakeridge Health and at the William Osler, where I was previously, played prominent roles and started some really wonderful initiatives for us. So happy to spend some time on that if you'd like. One other introduction that I'd like to do is I think Judy Linton is on the call. I don't know if Judy is here. I invited Judy to join us. Judy is the first Chief Nursing Executive of Ontario Health. And Judy joined us about 72 hours ago. And she actually started, as all of you would expect, as certainly I expected. My already favorite story for Judy is that Judy was supposed to start 3 days ago, but we connected about 10 days or so ago on a Sunday afternoon. Judy saw what was going on with COVID and said, "Let me in, coach." And so as any true to her form nurse and nurse leader, you can't sit on the sidelines. This is one of the things that I so admire of all of you. I also worry for all of you because I know all of you as nurses and nurse leaders, you're so committed to your patients and your communities, and you can't stand back. You have to get into the fray. But you also have to watch after your own health. And these are some of the challenges I'm sure you all face. But thank you, Judy, for joining, and thank you for joining Ontario Health. And I thought it was extraordinarily important that we have a Chief Nursing Executive at Ontario Health, a nurse reporting directly to me, a part of our senior team. Coincidentally, one of our other members of our senior team, Adol Khalfan, who just joined us to run our health system performance, is also a nurse by training. I try to surround myself by clinical folk, particularly nurses, because that's how I can ensure that the patients, the residents in our communities always stay at the front of what we do, because that's what is in all of your DNA. So it's wonderful to have Judy join us at Ontario Health. Just one last word of introduction for me, just on the personal side. So proud dad of 3, one's in the University of Nova Scotia, and so we haven't seen her in over a year, except through Zoom and all that sort of stuff. So the other 2, one I just picked up from Thunder Bay, and the youngest one is in high school. So nice to have them home. A little easier for me than perhaps for some of you with older kids. Younger kids, I don't know how you're doing it. If you have younger kids at home and you're taking care of them while you're trying to do your role and the pressures that are upon you, God bless you all for what you're doing. It really is quite phenomenal. Okay, so a couple of things we're going to do. I'm going to take you through fairly quickly just the technical side of Ontario Health. As Doris said in the introduction, we're a big merger, and we're merging. We haven't even finished merging yet, and I'll explain that a little bit more. Touch on the pandemic, of course, and then hopefully spend some time, maybe throw out a few teasers as to where the future might go, and then again see if I can do all of that and get it done in time for some questions will be my goal today. So just on Ontario Health, so what's on the screen right now, Connecting Care Act. If by chance you're having trouble sleeping, my advice would be is to download this and read it, and you'll have no trouble nodding off. What's important about it is that it's the act that forms Ontario Health, and it does a number of things. It describes what our role is and what our goals are. And it talks about us as the operators and integrators of the healthcare system. So big words, and we're going to explore a little bit what some of that means. It also talks about our drive for clinical excellence, and I've got a couple of slides on that as well. If you could give me a click, whoever's got the slides. Is that you, Catherine? Are you the one doing the slides? Yeah, okay, perfect. Okay, thank you. So just sort of a reminder of who we were. So on the bottom sort of part of that curve there are the number of agencies that have already joined us. Just to take a step back for a moment, at this moment in time, Ontario Health is actually still 15 separate corporations. And as of April 1, we were 16. We've gotten down to 15. And what has happened is, and again, I'm just going to give you the sort of the corporate ease of it for a second, just because it's the backdrop of what we're doing on the merger side. So most of the agencies that you see across on this slide, so you see the CCO, Health Quality Ontario, eHealth Ontario, all but the LHINs have merged into Ontario Health. So they no longer exist. There is no OTN legally anymore, as an example. The legal corporation of OTN is gone. It is now merged into Ontario Health. The LHINs still remain as 14 separate legal corporations, hence why we've got 15, right? We've got Ontario Health as one, and then the 14 LHIN corporations. The way that we operate as one, however, is that each of those 15 corporations have a board, but the board is all the same people. And so the board then, when they meet, we meet as the board of the 15 agencies. What the board has also done is I'm the president and CEO of Ontario Health, and then the board has delegated their authorities to me over the 14 LHINs. That way we can operate as though we're one agency. So that's how we've been operating. What happened on April the 1st is Trillium Gift of Life, which was the last sort of corporation that has now moved in. So that is now part of Ontario Health legally. The LHIN functions, so the performance management functions, the integration functions, those have moved over into Ontario Health. The home and community care functions have remained in the LHIN structure, and the home and community care functions will have a separate board and a separate management effective. We're working towards a July 1 date. And at that point, home care, its relationship to Ontario Health will be like every other agency, and it'll be an accountability relationship. We won't be actually operating the home care agencies as we do today. So that's a bit of the technical ease of what's going on in the background. You can imagine there's lots of change in there. That's 12,000 people who's all shuffling around, and we're trying to manage that as we go through the pandemic. And we can talk a little bit more about that if you'd like later. The last two comments from this slide is Core Health. You'll see the Core Health logo on there. Core Health has not merged into Ontario Health yet. Core Health, the transfer payment has moved over, so we fund Core Health through Ontario Health. It's anticipated that sometime, probably in around September, Core Health will officially merge into Ontario Health, and important sort of clinical parts of this. And then the Ontario Health teams, right now OHTs or Ontario Health teams are reporting directly to the Ministry of Health. The goal is to move them over so that they will report directly to Ontario Health. That has not occurred yet. Probably, if not for the pandemic, that would have already occurred. You can imagine, I speak to Deputy Helen Angus literally every day, multiple times a day, but we rarely get to talk about Ontario Health teams outside of the context of the pandemic. So that will also occur, and if you do take a look at Connecting Care Act, you'll see that it's in legislation that the Ontario Health teams will ultimately report into Ontario Health. So Core Health and Ontario Health teams are still a bit of a work in progress. Catherine, if you can give me the next slide. Thank you. Okay, so a question I often get is what's the relationship between Ontario Health and the Ministry of Health, and who does what? And I would say very candidly to you, this is a work in progress. We are figuring out exactly how these two things, how we're going to operate. I'll give you the technical and then sort of the cultural or operational. Okay, so the technical, as is described in the Connecting Care Act, the Ministry of Health is responsible for policy. Ontario Health is responsible for implementation. And Doris sort of referenced this a little bit in her introductory comments, in that the policies will come from government and then over to us to, within our scope, of course, to implement those policies. One of the things that's a little bit tricky is that in the legislation, they interchange the words strategy and policy. And of course, we know strategy and policy are not the same thing. So we're trying to work through exactly how this will work. And let me just give you a couple quick examples of how this is going. So I think that the ultimate way that this is meant to work would be, let's look at the cancer care model. So in the cancer care model, Ontario Health, through consultation with the field, I'm sure you're all familiar, or many of you would be familiar with the cancer care model, through consultation with the field, each year, Ontario Health would bring proposals to the ministry on, here's the things that the field, the experts are saying where we need to go as our next generation of cancer care. That comes back to the government. At the end of the day, the government, they're the funder, they're the elected government. They will decide which of the strategies we will move forward on, any policies that need to be implemented to support it, and then over to Ontario Health to work with the field to implement whatever is the proposal that has gone forward. So that's the ideal model. In cancer, we're all the way there in areas like mental health and addiction. So we're thrilled that Ontario Health, as part of our mandate, got the Center of Excellence for Mental Health and Addictions. You know, that again happened right before the pandemic. So we're still sorting out how does Ontario Health and the Ministry of Health work when it comes to mental health and addictions, and how do we evolve to a model that is more similar to what we're experiencing with cancer, as a for instance. I would say that the pandemic really got us to learn how to work together at hyper speed. We've sorted out a lot. It probably would have taken a lot longer had we not had the situation with the pandemic. I would say as well, and some of you would have seen it, there were times, particularly in wave one, where it was a bit confused, who's doing which part and all that sort of stuff. We were a pretty young agency when that pandemic hit. So I think we're much better now in terms of how the rules work and how we're going to work together, but still a little bit of a work in progress. Next one for me, Catherine. Thank you. I think I've already touched on a lot of this, you know, in terms of what we've been doing, a lot of focus already on COVID, of course. Service excellence. I don't think I'm going to walk through this slide, but I think I've already touched on it. And I noticed we're already down to about 10 minutes, so I want to get through a couple more thoughts. I would say just on the promote excellence, access, and continuous innovation, I want to go back to Judy's role. Judy is our chief nurse executive. She also, in a dyad relationship with our chief medical officer, Chris Simpson, have all the clinical programs reporting up into Judy. So those clinical programs would include cancer, renal, transplant, mental health and addictions, palliative care, and soon, when core health moves over, cardiac care, vascular, and stroke. So you can see all the really big programs, short of women's and children's really, are reporting up in through to Judy. And we have a real opportunity to look at whole person care. And this was the, you know, whether it works or not, time will tell, but the idea behind bringing all of this together under Ontario Health, and our desire to be a clinical organization as compared to a bureaucratic organization, is to see how can we bring, if you've got it all there, how can we do whole person care? And is there a way that by having these groups together, we can in fact enhance the care for our patients and our residents in our communities? And that's really part of the mandate for Judy. Nice and simple. How do you bring all those pieces? Here's all the tools. Now let's assemble them in a way that actually addresses care holistically for our communities. Next slide for me, Catherine. So this one, I think, just to say, a lot has been focused on the concepts of integration and where we're going to go with integration. And I would say for all of you who have been around for a while, and based on the view of the people on the screen, you all look so young. So I don't know how long you've been around the healthcare system, but we've been talking about integration for a very, very long time. And this is our next shot at it, as how do we get people working closely together. And this speaks specifically to that point earlier from Doris on OHTs, and how do we do OHTs and regional models of care, and sub-regional, and right down into very local. And I'm very passionate about that. And again, if we get a chance, we'll talk about that. Next slide for me, please, Catherine. In terms of our COVID response, again, I'm not going to walk you through all of these elements. I would say that we've been involved in most of the initiatives that have gone forward. Some we lead, some we support. It all depends on what's needed. And we've become a little bit of jack of all trades at Ontario Health, really trying to fill in whatever gaps are needed to fill within the system, and to try to bring that cohesion and coordination together. And again, echoing a comment from Doris, the COVID is absolutely awful, but a small silver lining in here is, I believe that to the degree that anybody didn't appreciate the need for regional, integrated, local care, we have passed that. We've crossed that bridge through this pandemic. That's how it's been delivered successfully. You can see it in the communities where there's great integration. Those communities have tended to have a stronger response and do better than other communities for sure. And so that's been one of the gains. I will just pick out on this page as well, maybe two other things. The COVID testing, again, for those of you who have been around for a little while, we've looked for a long time to get a provincial coordinated lab network in place. We didn't have one a year ago. We have one now, and we're very, very, very excited about having that in place. And so that's now a permanent feature of the Ontario healthcare landscape, and we can leverage that into the future, which will be great. Virtual care is the other one that I'll just touch on. I think you all know the numbers, or you've heard about the great uptick in virtual care. I think right now what we're looking at Ontario Health, among other things, is did the pendulum swing a little too far? We want to make sure there is some concern that there is a gap in care right now with respect to physical interactions, and we look at it through some of our preventative care, and so we want to try to level that off as best as we can. You can give me the next slide there, Catherine. Lessons learned, I think I've kind of touched on a lot of this, so I think I'm going to just skip. It's sort of listed there, the things that we've learned. I think I've commented on them throughout the conversation, so maybe just one last slide, and then maybe there's a couple minutes for a couple questions. Sorry, that as fast as I possibly could. On the future directions slide, a few things that I would just sort of call out. First is that we really want, at first, the other things I'll call out are in any order, but this one's not. This one is first, and it's health inequities. We have to go after health inequities. And if we knew they were there, and with the pandemic, we've only seen in stark contrast the health inequities in our province. And I'm happy to try to explain a little bit about what we're doing there. But in a nutshell, it's not so much that we want to do health inequities as a separate thing. We want to embed it in everything that we do. And in a great example, and the thing that probably has me the most excited coming into this role is getting the Mental Health and Addiction Center of Excellence. If we're going to go after the improvement of people's mental health and improvement around addictions, that necessarily means we have to go after health inequities, necessarily have to go after social determinants of health, and necessarily have to go after primary and community care. There's no other way to do it. So we're very, very excited about that, and I'm excited that we're going to try to embed these principles into that agenda. The other things that we'll look at, I've talked about the clinical excellence already, and the role that Judy will play. And just a quick example of what we want to try to do there is, we had the Ontario Renal Network, and we had the TGLN. These are separate things that would try to interact, and now having them under one grouping, one clinical leadership. What could we be doing to support people on their entire journey? To support them from going into renal failure, when they're in renal failure, how we're supporting them all the way through transplant and then back into the supports again. And those are the kinds of opportunities that we're going to have at Ontario Health. The regions and the OHTs give us a real opportunity at person-centered care and the things that we can do there. And then my last sort of comment would be, which I know appeals well to you as nurse practitioners, is everything needs to be evidence-based. We have, without doubt, the largest data holdings in healthcare in this province, probably in the country, but certainly in the province. We've got a tremendous amount of, a tremendous asset there in terms of clinical information. We want to make sure that that's feeding out to the front lines of care and getting evidence out there. And oh yeah, we have to finish merging. There's just that little thing as well. All right, I'm going to stop there, Catherine. And I don't know, I'm in your hands in terms of any
So,
time
Matt,
for some questions.
Matt, I will start with the first question. And as you know, never there easy questions. So hopefully you can give us shed some light into it. And,
Sure.
and congratulations on bringing Chief Nurse to Ontario Health. I was hoping when you brought Chris that you would bring a Chief Nurse. So kudos and welcome to Judy. The question is two pieces to the question. With straight answers, hopefully, if you are involved. I'm not sure to the extent, which I know Ontario Health is. The first one is vaccination. Is a mess, I cannot say nothing better in terms of the rollout. I will tell you from which perspective. Speed and simplicity is so cumbersome and is so unbelievable that 7,500 RNs and NPs in home care are ready to give vaccinations, to go to the warehouses, to do them in clinics, etc., and they are not allowed to this day. Second, we went into this pandemic, and you inherited this with the lowest RN per population in the country. The highest NP per population, but let me tell you, that's no good news, because compared to the US, we have a third of what the US has. Tell us a bit, especially with Judy in that role, what will you be able to do to fasten the speed at the bureaucratic level, because I doubt that the Premier is involved with the vaccination in detail, to speed up the use of nurses. You have nurses in primary care not being fully used. You have doctors in primary care not being fully used. You have home care, all the agencies, private and not private, wanting to join, hurdles in really moving it forward. And then on that end per population and then P per population, which are a solution to the system, not just now, going forward.
Great, thanks, Doris. So on the vaccine, so on that one, we don't have any particular role. So we do a support role at Ontario Health. So I really can't comment specifically. I would say I do see the gyrations. Perhaps I am an ex officio member of the task force. I see the gyrations. I can't really comment on who's next and how they're rolling it out. I would say, and I would welcome Judy to add a comment, because she's been on the job for 2 days. I'm sure she's got it all thought through.
Well, after 2 days, I was giving my speech to my AGM, so here you go. She can do it. She will do it.
There you go. She will do it for sure. I would say this. I think that a couple of examples for me personally in my professional career has been that the nurse practitioners have been able to bridge into roles that are very difficult otherwise, either because of the clinical mix or because of the way the funding models work. We're able to fill that gap with a nurse practitioner really, really well. And I'll give just 2 quick examples and then ask Judy if she wants to comment, just to try to save time for another question. When we looked at outreach, particularly into long-term care homes and into community, when I was at Osler, we set up a nursing outreach, a nurse practitioner. I'm not sure why the P didn't make it into the acronym, but nurse practitioner-led outreach teams. So that they would go out and try to support people in their home. They were hospital funded, but it was far, far better to have the nurse practitioner supporting them in the home, or in whether that home was long-term care or other homes, so that they didn't need to come into the emergency department. And it was tremendously successful. So there's roles like that sort of bridge those 2 worlds that I believe that nurse practitioners in particular are particularly well qualified for. The other quick example I would give is at our cancer clinic in Oshawa, again, where there's this level of support that's required for people who are going through the complexity of cancer care that we found the nurse practitioner was particularly well suited for. On the macro level, so I'll stop there. On the macro level, I think what we do need to tackle, and to be very straight talk to everybody here, we have to look at funding models of how these things work. Because right now there can be a disincentive to use nurse practitioners in certain settings because you can move the cost over to OHIP. And this is not the way to design the system. We should not be designing the system based on how the funding model works. So I've got some work to do there on making sure that we don't have disincentives for the right level of care built into our funding models. And maybe Judy, did you want to add quick comment, and then maybe we can do one more question?
Sure, just very briefly. Thanks, Matt, and thank you everybody for all the kind messages. You know, I have seen nurse practitioners be so effective in making things happen, in making discharges happen, and you know, I think there's a huge role for NPs going forward in the OHTs, and so you know, love to have the opportunity to hear more about your ideas about how those things would work. And as Matt says, it's very early days for me, and I'm a bit COVID focused at the moment, but would love to have more conversation with you about this. Thanks.
Terrific, Judy, because you hit the nail, because it's actually one of the recommendations in the NP Vision report, which we will send you, and we will meet with you to debrief you on that. The role of the NPs in the OHT, as you said, is absolutely essential, especially vulnerable populations that go through the OHT. So thank you.
Thank you so much, Sally. Maybe I'll turn the mic to you. I see you have a question, and then from there we'll go in order of receipt for questions.
Yeah, thank you. I actually want to say thank you for being here and speaking to us. It's great to hear right from the top. The other thing I want to comment on is, I know COVID is such a focus, but what better time to utilize the nurse practitioners and the nurses in this province, because we are ready. We are very ready. So my question isn't so much of a huge question. It's just, what is the ability, your strength to empower those who direct, at least my directors, my managers, to be able to redeploy us. I think I have many colleagues who are ready to hit the ground running, and we actually are restricted from stepping up to the plate.
Mm-hmm. Thanks, Sally. I think that the best advice that I can give on that one is perhaps you can connect offline with Judy, because right now, and just to sort of pour very cold, stark water on everything that we're talking about here, if the latest projections come through, we will need to figure out how we're going to support 2,800 more hospital admissions and 800 more critical care admissions over the next 3.5 weeks. So this is a all hands on deck moment. And we do not want particularly skilled resources, skilled people like nurse practitioners underutilized in any possible way. We just cannot afford that as a system. We can't afford it anytime, and we certainly can't afford it right now. So my best advice is to maybe reach out to Judy directly, so we can see how we can take it to support you, to support us. That would be fantastic.
So I want to augment that though, Matt, because it's not as if we didn't connect with Ontario Health or with Helen directly or with the Minister or Premier. We actually requested to redeploy them in the first wave to long-term care. That didn't happen. And Judy's 2 days in the job, with due respect. I doubt that she can make it happen by herself. It's you really that needs to talk with Helen directly and redeploy them. You're hearing from them. They're frustrated that they're not helping on the ground. And if you get pulled, and it's 4,500 RNs and NPs that are asking to be redeployed. They did during long-term care, didn't happen. I don't actually know what the role was that they did, because there was no home care really for them to coordinate. You need to take it on, and you need to make it happen. And then Julie can operationalize, but those are decisions at the top of why they're not. And talk with Catherine Brown, ask her. Same on the vaccine redeployment, by the way. Being honest, this is urgent. This is not a process that you can delegate to a colleague that, with all due respect, she can then work on the details, but these are decisions at the top.
Thanks.
Thank you, Doris. There is a member in the audience with the initials AD that has their hand up. Would you like to ask your question?
Yes, I would. This question is for Matthew Anderson. I have a question about the COVID-19 testing. We're supposed to be doing evidence-based practice, and to the best of my knowledge, the COVID virus has not been grown in the lab. And so, and also there's some question about false positives with the PCR test. And this is what I need to clarify. With all the numbers, has there been a lab confirmation of all these numbers that are being projected, like actual science? To the best of my knowledge, when we checked with Health Canada, they had no data on an actual virus being grown in the lab. So this is what I would like to know. And then there's the rollout of the vaccines. And the other part of it is informed consent related to this, because it is an experimental vaccine. So those are my questions, and I'd like you to respond. Thank you.
Sure, thank you. So again, I can't really comment on the vaccine on the lab. So we did do the original science testing on the test itself. So we have been able to confirm that the test does result in a very low rates, extremely low rates of any false positives. We don't do it off of every exam, but we did do it off of the original test that was established, and that was established in the lab at PHO. So we do have great confidence in the quality of the result, and that the numbers that are being produced do in fact represent an appropriate level of positives within the environment. On the informed consent part with respect to the vaccine, my understanding is that, well, for me and for everybody else, that they would have to sign on informed consent. But I only know what the same as you in terms of what's in the public domain on that.
Thank you, Matthew.
Thank you.
Okay, we'll move it now to May Cat. I saw her hand go up next. May, would you like to unmute yourself and ask your question?
Yes, good morning, Matthew and Judy and Doris and everyone else. So I work in northern remote communities in a territory called Anishinaabe Nation. Again, we've struggled for many years with opioid addiction as well as a suicide crisis. We're still not, you have a priority for marginalized populations, and I didn't see Indigenous peoples down there. And I'm just wondering, Matthew, if you could let me know what your priorities would be for Indigenous people who live on reserve, as well as those who have to come to Thunder, other cities, urban locations to receive tertiary care, including cancer and renal care.
Great, thank you, May. Thank you for the question. So one of the things I have been able to do, perhaps not at the exact rate that I would have liked, is to meet with all of our Indigenous communities. Like this, unfortunately, I haven't been able to go and travel to them, but we've been doing it by Zoom to understand what would be the best way for us to be able to support each of the communities. As I have learned, there's definitely not going to be a one-size-fits-all here. And in fact, as we've met with the different communities, they've sort of pointed that out to us directly. Each of the communities that we've met with so far, I would say almost all, if not all, have established for their community their health priority plan. What we want to do is support that plan as compared to come in and tell them, no, here's our plan. And so we've been enumerating with each of the communities as we've gone through, and I've met with, I think, almost everybody across the province at this point to make sure, and what we're doing, so we have an initial meeting with them, and this has all been happening in the last few months. They send us over their plan. We're then doing a follow-up meeting to say, how can we support that plan? And be honest, like there's places where we can support, there's going to be some parts that we aren't going because of resources or whatever, but to make sure that we're working hand in glove and trying to be very specific about not telling communities how we're going to support as compared to understanding what they need and what their priorities are. So that process is underway right now, and definitely includes the community that you're talking about in the communities through Northern Ontario. We are doing both. This is for both on reserve and off reserve, and working through the chiefs and the health policy advisors. Most of the communities that we've worked with, the nations, pardon me, that we've worked with have a health policy advisor of some description, so we're working with them directly through them.
So May will not say it herself, so I will say it for her, Matt and Judy. She is the guru in the area of Indigenous health. She was extremely involved in the redeployment of vaccination with the Bogosh and all of them, and Tien And if there is a success story in this country, it's actually what happened with vaccines to our First Nations community. So it's a silver lining, and can be of huge, huge, huge help to the ministry in really looking at basically Indigenous people's health. I also want to mention Arik. I think Arik is somewhere there. Say hi, Arik. He is one of my sons, I say, kind of adopted son, not son. One is my guru, the other is my son. Involved since he was really a student in nursing with RNAO. He's doing his PhD in the area of Indigenous health, well advanced in his PhD. Those are two individuals amongst others in the group of already 300 people that can be of support. So anytime, and I'm saying this to Judy, I'm saying this also to you directly, Matt, anytime that the ministry needs support from nurse practitioners in specific domains or clinical areas, or please ask us. That doesn't happen, Matt. That doesn't happen. Because we have the cream of the cream. We have 46,000 members. The cream of the cream of nursing are members of RNAO, and all, as you heard Sally saying, we want to do more, not we want to do less. So please access us. We will give you the contacts, and they will be supporting the work that urgently needs to happen.
Wonderful. Thank you, Doris. And maybe May and Eric, if you could email me after this, just so I've got your email addresses, that would be fantastic. Thank you.
Yep, sure.
Wonderful, thank you. So we have about a minute left. Maybe we will ask Tina, I know you've had your hand raised for a while now, to ask your question.
Hi there.
Hi, Tina.
Yeah, I guess I was just wondering what the, like in speaking of integration of all of these different organizations, the compensation for NP roles across the province just varies so greatly, despite the funding coming, for an NP position from the ministry. I think in primary care, a few years ago, we got the recruitment and retention funding, and everybody stood up and, yelled and celebrated about that. But it's been rolled out so differently across all the organizations. And I'm just wondering what Ontario Health, what their role is going to be in helping ensure there's pay equity across the province for nurse practitioners in their roles.
Yeah, thanks, Tina. And I would say that so this is a great example, going back to my earlier point about what does the ministry do, what does Ontario Health do? To my mind, what we need to do is make recommendations back to the ministry on what are the, and in this particular instance, sort of compensation impediments. Are there funding impediments? What are the things that need to change in order to ensure that we're optimizing from a clinical perspective what needs to go on? So we need to make those recommendations back to the ministry, at which point, the ministry, they have to make the decision, but we try to get as best information back to them as possible to highlight where we have discrepancies or disparate practices that are impacting the health of our communities and the services that we're providing. So that's our job to do that, and then over to the ministry to determine what they're able to accept and what they're going to fund.
Perfect. Thank you so much. We are almost out of time. Well, we're at 10:01 now. So Matt, there were a number of other questions in the chat we unfortunately didn't get to, and I apologize to those who didn't have the opportunity. We will be in touch with you after the event, so we'd be more than happy to share some of the remaining thoughts we didn't get a chance to discuss, and as well as to provide some connections to you as well to make sure that we can follow up on some of the discussions for today. Doris, do you have any closing thoughts for Matt before you leave?
No, number one, simply to say thank you, Matt, for the tremendous and long hours that I know you all are putting, as we are all. And also, please access the expertise of people in the front line. You have, as I said, the cream of nursing, 46,000 members, including 2,000 NPs with variety of specialties. I just mentioned in the chat Beth Sweeney, who is involved in the task force on primary care representing RNAO, And like that, I already mentioned 3, but I could mention to you, 2,000. People eager to help, eager to wanting to do more. And I will leave you only with one thought, which is echoing what Sally said. Sally Berg, the chair of the Nurse Practitioner Interest Group. Deploy the 4,500 care coordinators. There is not a lot of surgeries to be doing now coordination on home care, unfortunately. Deploy at least 4,000 of them. People are desperate in the ICUs and in the hospitals. Use the talent that wants to be there. Use it. And now we are moving 1,500 people to nursing homes from the hospitals, Matt. 1,500 within the next 10 days. You know that because I got the memo that you sent to the hospitals. The capacity is not there, you know it. So you have those care coordinators, send them to long-term care to help. Otherwise, it will be another fiasco, long-term care, and they can't afford another fiasco. There is talent, use it, because nurses want to be useful to this crisis that we are in. So, just push it, meet with Ellen, that's the level, and then Judy and I can plot how to move it fast. But the decision doesn't come from a Judy or from me. I have been asking from the beginning of the pandemic.
Great, thank you. Thanks, Doris. Listen, everybody, thank you so much. Hopefully you'll invite me back another time. And maybe we won't be in a pandemic and we can be in a room or something like that together.
Maybe.
Wouldn't that be wonderful? Wouldn't that be
hope
wonderful?
So.
Thanks, everybody.
Thank you so much for coming.
Bye now.